Hello, I'm Dr. George Ampat. A warm welcome to all of you who have joined us today for this MSK special interest group day, where we are looking at different aspects of MSK and lifestyle medicine. Thank you very much. Now, what I'm going to talk to you about is on walking and back pain. So we are looking at the walk back study, and the learning outcomes would be the background information, what is the inclusion and exclusion criteria, what is the walking prescription, the educational principles they used, the results and limitations, and finally any conclusions. So just to give you a background, I'm an orthopedic surgeon and I work at Aintree University Hospital, which is a major trauma center. And I also teach in the School of Medicine at Liverpool University. I'm a clinical teacher at the School of Medicine. Now, my disclosures are that I have websites and I promote exercises for musculoskeletal pain. So on my website, My Self-Help, you will find exercises for back pain, neck pain, hip pain, and knee pain. And I also sell self-help books. So these are two of my books on Amazon. And they are mainly targeted towards older adults who have musculoskeletal pain, especially arthritic pain, and how that can be helped with exercise regimes. So looking at the learning outcomes, the walk back study. This was recently published by Pocovi et al. In June, and it was published in the Lancet. And it's a landmark study. But prior to that publication, the same authors had published two previous articles. So one was in 2020 when they published how they were going to do the study. The protocol of the study was published in 2020, and last year in 2023 they published how they were going to do the statistical analysis for the same study. And finally, at the end of the study, it was published in June 2024. Now, the first author is Dr. Natasha Celeste Pocovi, who is a physiotherapist, and this study is from Macquarie University in Sydney, and all the participants and even the clinics that were involved were around the Sydney area in Australia. What is the background information and what created what was the force behind or the reasoning behind creating the study? So one, we know that low back pain is very common. Currently, about 619 million people have low back pain, that is in 2020. And it's estimated that by 2050, 843 million will have low back pain. We also know that once you have an episode of low back pain, there is a 70% chance that there could be recurrence within the 12-month period. And we also know that these recurrences only increase the economic burden. It could be direct cost and indirect cost from absenteeism, indirect cost, and direct cost is from the medical cost itself. What do we know about exercise? We know about exercise that when education and exercise is given together, they benefit in low back pain and decreases associated disability and work absenteeism. But usually exercise-based interventions are group-based, and once you have a group base, you have a health professional or someone participating in these exercises, so it increases the costs. Then there is also a potential of whether it is accessible. Now, when there is a group class, then you need to accommodate your time to go to that class, and it may not be suitable for you. It may be during working hours. Or you may have anxiety. You may have, like for me, I'm slightly large and I don't want to be in an exercise class where everyone is the lean, mean fighting figure and I'm a pudgy me. So maybe we want to have our own space to exercise. So there are some limitations of group classes for exercises. Now, looking at walking, it is a low risk exercise and it can be adaptable to lifestyle. You can do whenever you want, even if you're busy, you can always put some time, allocate for that. And it does, it is universal. Anyone can do walking. You don't need to be a part of a gym. You don't need to join a gym. You don't need any equipment. It is easily accessible. And we also know that walking has a lot of health benefits: cardiovascular health, improved cognition, mood, reduced non-communicable disease. So already we know that walking is so beneficial. But though walking is beneficial and though we have identified that walking can have a lot of health benefits, there is no trial as of yet looking at the effectiveness in preventing recurrences of low back pain. So that is still wanting in medical literature. So how did they do this study and what were the inclusion and exclusion criteria? I'll tell a little bit more other than just limiting myself to the inclusion and exclusion criteria. So they defined back pain as, so it is non-specific low back pain and it's acute occurrences of back pain, not chronic low back pain. And they defined back pain as any pain that occurs from below the rib cage to above the gluteal fold. So any pain in this area was classified as back pain. But they were very particular that patients whom they identified did not have a known cause of back pain, and hence it has to be a non-specific. So if you look at these three images, that just gives you some of the exclusions. So if it was the back pain was identified as being due to metastasis or secondaries in the spine, it was excluded. Or if it was identified that the back pain was from infection or spondylodiscitis, that was excluded. Or if it is identified that the back pain was from a trauma and fracture, then those were excluded. So basically any back pain that has an anatomically identifiable cause other than just age-related changes were included in this study as non-specific low back pain. How much pain should you have to be included into the study? So on a scale of 0 to 10, one should have a pain score of more than either 2 or more than 2 to be included as having an acute episode of back pain. They also use one more criteria, and that is from the Promise Health Organization. Promise is a US-based National Institute Health funded organization, and they have patient-reported outcome measurements for nearly all issues, medical issues. And they have one for back pain, and one of their criteria is how much did low back pain interfere with your day-to-day activities, and people had to score either somewhat or greater to have experienced back pain or where they were included into the study. How did they note recovery? If you had recovered, then your pain score should be 1 or lower over a period of at least 7 days. Only if it is 7 days or over, then one can state that that particular patient has recovered. So inclusion was all eligible adults who were more than the age of 18 who recovered from an episode. So you had to have there was an episode of back pain following which they recovered following that, and then from that point on, from their inclusion into the study till they get the next episode of back pain, that is what is looking at the primary outcome. There were, as we looked at before, there were exclusion criteria. So also, if there are any comorbidity preventing participating in a walking program, or they were already walking, or they were regular participation in an exercise program like Pilates, or they were achieving 150 minutes of moderate or vigorous intensity physical activity, or if they had spinal surgery in the preceding 6 months, or if they were pregnant, or an inadequate level of English to complete this, they were excluded. So totally you can see from this study, they contacted nearly 3,206, and finally they accepted 701 patients who were randomized. They were randomized into two groups. The chance of being in either group was 50%. There is one group of 351, they were assigned to the intervention group, and the other group of 350, they were assigned to the control group. They were all given, the patients who were on the intervention group were given a clear walking prescription. Now I know we are looking at just a study, but it's important we also know what prescription we need to give our patients if we are going to use walking as a method of treating their low back pain. So as I said, this is all the physiotherapists around Sydney who participated in this program. And the people who were in the intervention group had 6 consultations with the patient. The initial consultation was an examination, history taking, and they were given a pedometer and given a diary to track their walking for first 12 weeks. Then there was a follow-up at 2 weeks, which is a telephone consult, follow-up at 4 weeks, which is a face-to-face, at 6 weeks, a telephone consult, at 3 months, a face-to-face consult, and at 6 months, there was a further telephone consult. All the physiotherapists who were involved in this, there were about 25 physiotherapists, they had been through health and wellness coaching certification and online certification, and they had done that, and hence they were able to empower these patients to do exercises. And the prescription was, this was what was followed. Patients were classified according to a label or a color. So either they were red, orange, yellow, green, or blue. Now you can see that there were two criteria. The age was taken into one consideration and how much of walking they were doing. So if someone was 65, over the age of 65, and they had limited walking in the previous week, less than 30 minutes, they are in the red category. If they were, on the other hand, if they were walking more than 30 to 60, they are in the orange. Similarly, someone who's less than the age of 40 and was actively walking more than 60 to 90 minutes in the previous week, then they were considered blue. According to each color code, the amount of walking was prescribed as per this chart. So if you were red, that is, if you're old and you are not doing a lot of physical activity, then you're starting the walking program with only walking 10 minutes in a day, and you're doing it only 3 times per week. And in 4 weeks, you're trying to achieve 15 to 20 minutes of walking 3 times per week. Once you do that, then you go to the next level. You're on orange, you do 15 minutes 3 times a week, progress to 20 minutes 3 times a week. Then you proceed to yellow, green, and blue, and potentially at each one is a 4-week duration or for a month. So potentially in 5 months time, you're walking 30 to 40 minutes. You're doing it 3 to 5 times per week. And it is usually the intensity is you're walking quite vigorously and you're slightly breathless, or you're having the Bog scale of 13 to 14 that shows amount of breathlessness or the intensity of the activity. Patients are also given this walking diary, so they would mention in the diary how many minutes they walked, and if they could, on the pedometer, the steps they counted on the pedometer. And there was a small box on the top right, you can see, which is they had to mention whether they experienced back pain that day or not. And this is how they meant it. So this diary is for 28 days. You can have that diary, and they did it for 3 months in the beginning. Then they were given some education. Basically, it was pain management and how do you handle pain, especially if you're participating in this trial. So there were 4 main principles. So what happens if there were minor recurrences of pain? Then the patients were told, well, this is okay. You're likely to experience some minor recurrences of pain, especially when you exercise. That is perfectly all right. They were reassured and asked to continue with the program. Some people were worried that certain particular activities aggravated their pain, but again it was reassured that the spine is strong, that the disc can't just slip like that, and that as we increase the strength, the spine becomes even stronger. And people were also asked to pace, like if a particular activity couldn't be done, they could pace on that activity, do a little bit of that activity, and slowly as their spine becomes stronger, they would be able to do that activity better. People also had some myths and misunderstanding. They thought that they had to always sit straight in a chair, but that is not, that sitting straight and stiff is not normal. Actually, sitting without any movement could be harmful. So patients were told that you don't need to have, keep yourself always stiff and keep a straight spine or sit in a straight way. Try to move. Movement is important, and movement is important for the back. So that was the third educational principle. And the fourth is, what if there was some significant recurrence of pain? Patients were told to still remain focused on the exercise and remain active, even if they can't do the walking, but as to remain as active as possible and not to focus on the pain. Once they focused on the pain, it would be that their outcomes would be worse. So they were advised not to focus on their pain. So what results did this study achieve? They looked at, these are all the primary outcomes and the secondary outcomes, they had looked at different values. And so as I mentioned earlier, there were about 701 participants who were randomized. So 351 to the intervention group and 350 to the control or the usual care group. And now you can see the Kaplan-Meier score of how you can see the the above is for the control group, the bottom is for intervention group. This shows the Kaplan-Meier of activity limiting episode. So when they joined the trial, so they had a back pain, then they recovered from that acute back pain. Then they joined the trial. Then when do they get another recurrence of the back pain? That is, and it has to be an activity limiting experience, that is a back pain. So it is not that you just had a bit of back pain, but you're continuing with normal day-to-day activities, then it wouldn't be considered. It has to be an activity. You're not doing something because of that back pain. And you can see that over a period of time, the control group, which is the blue colored graph, the control group, which is the red, is greater than the the investigation group. The investigative group is having a far lesser amount of back pain, recurrences of acute low back pain. So if you look at it, cumulative activity limiting episode for the intervention group, you had to wait for 208 days for one more activity limiting back pain, whereas in the control group it was much shorter. Within 112 days there was a cumulative activity limiting episode of back pain. This again the Kaplan-Meier of back pain that necessitates you one to go and seek advice from a health professional. So earlier we looked at back pain that was activity limiting, but you may not seek advice of a health professional. So here it is, the back pain is more severe, which necessitates you to go and seek the advice of a health professional. Again, we can see that in the control group there is more episodes than in the investigative group, which is blue, which is a lower line. Now, if you look at the days, the intervention group, they saw a care-seeking episode was in 295 days, whereas in the control group, cumulative care-seeking episode for 116 days. Then they looked at the incremental cost ratio, and the incremental cost per QALY gain. So one QALY gain was Australian dollars 7,802, and that was a 94% probability. And the Australian authorities, the willingness to pay threshold is $28,000. So this is much less than the willingness to pay. So it is good value for money, this intervention. And they also found that the intervention was effective in preventing an episode at a hazard ratio of 0.72, which means if you take the other way around, it's 28% reduction of the recurrence of back pain by just walking. But there were greater number of adverse events. They were not statistically significant, but the people who were walking had more lower limb injuries, aches and pains as compared to the group that was not walking. So 100 in the intervention group to 55 in the control group. But from the study, were there any limitations? There were some limitations. One, chronic low back pain were excluded from the people who agreed to participate. 2,505 were excluded, nearly 78% were excluded. And number two, is it a real comparator? Because we have to compare apples with apples, and you can't compare apples with oranges. So in this study, what we see is one group, the group that is being investigated, have a specialist set of physiotherapists seeing them for 6 occasions, and then they're asked to do walking. Whereas the control group don't get that consultation with the physiotherapist. And these physiotherapists are not just ordinary physiotherapists, they are trained physiotherapists. In addition, they have gone through a health coaching health coaching program. So they really know how to empower patients to do the exercises. So they are actually very good physiotherapists. Now, even if you don't have the walking, if you just have such good physiotherapists talking to patients, maybe they will do well. Just encouraging them will do well, not even telling them to do walking. So that is potentially, is it a real comparator? The number two, you can see here, this is one of the EQ5D, and yes, at the baseline, there is no difference between the two groups. At 3 months, there is a difference. But coming to 6 months, again, you find no difference between the intervention group and the control group. Similarly, if you look at the self-reported physical activity, how much are they walking? At 3 months, you can see there is a significant difference. The intervention group is walking, but the control group, actually within 12 months, there is no difference. So they have started walking by themselves, though no one has told them to walk, because they know that they're steady. And it's also possible that the investigative group had decreased their walking ability. And unfortunately, this was during the COVID pandemic period, and lots of people started walking at that period. And it's possible that is why, even though you were not in the control group, you just wanted to be more fit, and one started walking. But what are the conclusions that we can gain from this? Now, just like all the 6 pillars of lifestyle medicine, we know that this walking intervention definitely helps with daily physical activity. So one of the pillars of lifestyle medicine, and that daily physical activity is likely to give you better restorative sleep, is also likely to decrease your stress because of the factors of the exercise itself. And number two, if you're walking along with other friends, or then it's going to inculcate some positive relationships. So we looked at all this today: the walk back study, the background information, what were the inclusion, exclusion, walking prescription, there were education principles, how they motivated them, and we looked at the results. We also looked at the limitations, but finally we concluded that walking was a good intervention for recurrences of back pain. But what we don't know is for chronic back pain, but doesn't mean that it cannot be tried. I hope all of you will be attending the BSLM conference this year in 2024. That is going to be in September. It is going to be in Newcastle, and I mean, please look at our website for further details. And I look forward to seeing all of you at the conference. Thank you very much, and let me know if you have any questions.